Excellent. Here they come in.
Have you guys liked doing grand rounds as webinars?
It's a blessing and a curse. You know, the flexibility is nice, and you know the convenience, I think, for a lot of people is nice, but we definitely miss that physical presence. You know, we've started to do a few of them hybrid, where there's a couple folks in person, and I think that's been really great. Just even, you know, for our speakers, just to see some reactive faces and connect to people.
Yeah.
How about yourself? Have you done some in person again, or are you all Zoom?
We're all Zoom.
Yeah.
We're all Zoom. But they don't do it in the webinar format. They do it in the regular Zoom, you know, the 200 people all on the squares, most of whom who don't have their cameras on, and probably you should be doing it in the webinar so you don't get folks entering and not knowing that they have their sound on or cameras on. And but
yeah, when this works, the webinar format works pretty well.
We've been doing our interviews for internal medicine they're doing a webinar interview, but for our med peds and primary care track, we do it with regular Zoom, and it's nice to be able to see people's faces as you're
talking. For sure. Well, let's get going if you're ready.
Sure.
All right. Good morning, everyone. Welcome back. I'm John Hickman, one of the chief residents of internal medicine, and it is my pleasure, as always, to welcome you back to Grand Rounds here at Washington University School of Medicine. On behalf of our chair, Dr. Frazier, Dr. Costco Spencer, and myself, we're just so happy you're here. I am very excited about today's speaker. You're going to hear more about him in a moment, a real powerhouse from Johns Hopkins joining us today. As always, please head over to the Department of Medicine's website. Check out our YouTube page for any talks you've missed in the past, or this talk if you want to review it. We also have a new spot there for you to send us some feedback. We'd love to hear from you about your thoughts on this talk, past talks, talks you want to see, speakers you're interested in. We'd really appreciate any feedback you could provide. At the end of this talk, please again send any questions you have through that chat or Q&A function. I'll help to moderate that with our speaker at the end, provided we've got time. And here to introduce our speaker, we have our very own Dr. Chris Prater. Dr. Prater is an amazing physician, works in our primary care clinic. He's a primary care physician himself, takes a lot of care of international refugee populations here, does a lot of work in terms of tuberculosis, and has appointments both in the medicine department as well as pediatrics. A real pleasure to have you here, Dr. Prater. Thank you.
Thank you, Dr. Hickman, and it is my pleasure to introduce our speaker today. I too am excited to hear about Dr. Lenny Feldman. He is an associate professor in internal medicine and pediatrics and a hospitalist in the Division of Hospitalist Medicine at Johns Hopkins University School of Medicine since 2004. He received his undergraduate degree at Brown University and his medical degree from the University of Maryland School of Medicine. He completed his combined internal medicine pediatrics residency at the University of North Carolina, where he served as chief resident for the internal medicine residency. He is the founder and program director of the Johns Hopkins Combined Internal Medicine Pediatrics Urban Health Residency and the Osler Urban Health Internal Medicine Primary Care Track. He's also an associate program director for the Osler Internal Medicine Residency. As a hospitalist, program builder, and a specialist in resident and hospitalist education, Dr. Feldman has focused his research on urban health, resident education, online education, and high-value care. Other interests include patient education, consult medicine, evidence-based medicine, and quality improvement. He's the editor-in-chief for SHM Consultative and Perioperative Medicine Essentials for Hospitalists, and a deputy editor for the Journal of Hospitalist Medicine for the Things We Do for No Reason series. Please welcome our speaker, Dr. Feldman.
Thank you, Chris. Very kind introduction. It's really wonderful to be here. And I bring warm greetings from Heather Satay, who I understand was a former chief resident for you guys and here at Hopkins now, and has been serving as our interim internal medicine program director for the last couple months as we recently found a new program director for internal medicine. Dr. Natasha Chita. I'm going to talk about something probably a little bit different than what is usually talked about at Grand Rounds. I'm going to talk about my experience with urban health training here in Baltimore City and hopefully make it a call to action. Here are some of our objectives for the day. We're going to talk about some of the structural and social determinants of health affecting both Baltimore and St. Louis. Our cities are actually very similar. And I think where our hospital sits, the communities that surround it are very similar. Going to describe why we thought an urban health track was needed here in Baltimore City at Johns Hopkins, a little bit about the basic structure of our programs, and review some of the curriculum that we developed to create leaders in urban health primary care, and then talk a little bit about the effectiveness of the track and maybe some next steps and things to think about. So it's a little harder to do this on Zoom, but if you guys would, while you're sitting wherever you are at home or at work, say these words out loud with me: fat, flu, behavior, exercise, menopause, rectal, antibiotics, anemia, and jaundice. So my guess is that all of you said these out loud correctly. This is part of the rapid estimate of adult literacy in medicine, the REALM test. This is a test that you can see the citation is from 2007, a test that was created to try to very rapidly assess whether your patient is literate in health matters. And so the way that the test works is you have your patient say these words out loud. Obviously, it needs to be in the right language. And depending on the number that they are able to say out loud and pronounce correctly, that correlates to a reading grade level. So I assume that all of you, there are 8 words. The first one you get is for free. And then you have 7 more. I assume that everybody here today got all 7 correct. You have a greater than 9th grade reading level. And I will tell you that we did this with our patients here at Hopkins. We did a health literacy study. This was back in about 2010 now. So getting a little old, but I don't think very different these days from when we did this back in 2010. And our intent was to look at our patients here in Johns Hopkins. So Johns Hopkins, and I'll talk to a little bit more about the hospital, sits in East Baltimore. And in Baltimore, we have no safety net hospitals. In Maryland, we have no safety net hospitals. The safety net hospital is the hospital that sits in your community. It is your community hospital. So Hopkins, even though many people think about it as a tertiary quaternary center, and certainly we do our fair share of all of that work, at heart, Hopkins is a community hospital. So we were talking to the patients who were in our hospital, who are our community patients, and we interviewed 60 of them. In the end, 70 patients were excluded for a variety of reasons. But we ended up interviewing 60 of them and doing our health literacy study with them. And the patients that we enrolled had to either be on long-acting insulin, so needed to be able to do the math, to be able to do long-acting insulin, or were on anticoagulation with Coumadin. We did not have any of the DOACs then, so it was still Coumadin for everybody. And the patients needed to be able to figure out how many milligrams of Coumadin to take on a regular basis and what that would mean for their INR. So when we did that literacy test with our patients, just if you could think about what you think may be the percentage of our patients here in Johns Hopkins that had a less than 3rd grade reading level. Is it 20%, 40%, 60%, or 80%? So just think about that for a moment. Come up with your own answer. And here is the answer. It is 20% of our patients who had a less than 3rd grade reading level and a full third of our patients who had a less than 7th grade reading level. About a third of our patients with greater than 9th, about a third 7th to 8th, and a third who are have a less than 7th grade reading level. Means 1 of every 3 of your patients that you see, or that we see here, has a less than 7th grade reading level, and 1 out of every 5 who has a less than 3rd grade. And my guess is at your hospital, having done some research on the communities surrounding Washington University, that your numbers are pretty similar at Barnes-Jewish. We also had them do a numeracy assessment tool where they were asked these 3 questions. I'll let you guys read the questions and see if you can come up with the answers. One is a question that is trying to see if you can estimate a simple probability. The next one is about converting a percent to a number. And then the final one was to convert a number to a percent. Give you a few more minutes or seconds to read through this. So we asked these 3 questions. We gave them more time than we're giving you. But then again, what is the percentage of patients who could not answer any of those math questions correctly? Is it 20%? Is it 40%? Is it 60%? Is it 80% who could not answer any of those math questions correctly? And again, this is a patient population that had to do anticoagulation with warfarin and or were on insulin, long-acting insulin, and had to be able to figure out how much insulin to give themselves. And oftentimes patients who get sliding scales when they go home, things like that, that are quite difficult to do. So it was basically a full 60% of our patients who could not do any of the math questions correctly. So 20% of our patients with a less than 3rd grade reading level, a third of our patients with a less than 7th grade reading level, and about 60% of our patients who cannot do any of the math questions correctly. That should lead you to ask questions about the health literacy of every patient for us that we come in contact with here at Hopkins. And my guess is numbers, again, are very similar at Barnes-Jewish at WashU. And where does a lot of this come from? Why do we have the issues that we do? And certainly, I think this is not going to be a surprise to all of you. We have a terrible issue with racism and racial segregation here in Baltimore, and a very, very long history of racism and racial segregation. So you can see where the African-American population lives in Baltimore City, and where the poverty is in Baltimore City, which is the red here. The poverty rate is above 20%. And what people will call this is the black butterfly and the white L. So you can see this sort of white L that comes down the middle. This is the affluent parts of Baltimore City, and also the white parts of Baltimore City. And here are the African-American parts of Baltimore City, which also in general correlate with a high poverty level in Baltimore City. Here are neighborhoods with poverty levels that are greater than 40% or 30% to 40%. And again, you can see that it's this black butterfly and then the white L that comes down the middle where the poverty level is quite low. And Lawrence Brown coined this term, the black butterfly, and has a great book if you want to read about Baltimore politics and Baltimore issues, about all of the racism and policies that led to the racial segregation and the creation of the black butterfly here in Baltimore, which is not at all different, it sounds like, than what has happened in St. Louis. Here are present day African-American population by zip code in St. Louis, and clearly significant segregation going on here as well. With I believe this, I put a star where I think Barnes Jewish sits, where WashU sits. Here is the highest density of African Americans in St. Louis, and then up into North St. Louis, and then when you go out into St. Louis County, very few African Americans in St. Louis County, and I think a very similar history of racial segregation in St. Louis. I think the similarities between our two cities are vast. This is a graph of dissimilarity. So what are some racially integrated areas in St. Louis? What you will quickly notice is that out in St. Louis County, there are areas that are not integrated at all. They are very segregated, and in terms of out in St. Louis County, that means a lot of white people out here. And then you can see that there is some of that issues with segregation here, and it's sort of this swath in the middle that is the highest area of integration. And actually, it looks like Barnes Jewish sits about in that area, but certainly bordering regions of very low integration and high segregation. So I'm going to talk about Greenmount East a significant amount here. The reason I'm going to talk about Greenmount East, which I'll show you where it sits in Baltimore City, is because it is where East Baltimore Medical Center sits. And East Baltimore Medical Center is a community clinic. It is where our MedPeds clinic is housed. It is where about 1/3 of our internal medicine residents do their continuity clinic. It is where all of our internal medicine primary care residents do their continuity clinic. And this is just a picture from the other day with our leaves changing here in Baltimore. So here's Greenmount East. Johns Hopkins, if you could see my pointer, sits right about here. It's just a little bit south and east of Greenmount East. It takes me from driving from Hopkins to East Baltimore Medical Center. It's a 3-minute drive for me. So they're very close together. So you have Greenmount East over here where East Baltimore Medical Center sits. Chris Prater used to work around here in the Highlandtown area. Oh, here's Highlandtown, in the Highlandtown area when he was here in Baltimore City. Sandtown, Winchester gained national prominence with the Freddie Gray uprising. Many of you probably remember the Freddie Gray uprising in 2015. Freddie Gray was a young man who died in police custody, who was murdered in police custody, and the city rose up as a result of that. All of the police officers involved in that death were not found guilty. So it was certainly pre George Floyd and police officers being held accountable when they actually are killing our citizens. Up here is Roland Park. And Roland Park is one of the most affluent areas in Baltimore City. I'm going to do a lot of comparing and contrasting between Roland Park and Greenmount East. As you can see here in the bottom, they're about 7 miles between Greenmount East and Roland Park, but where you grow up in those places could not be more different, even though they are only 7 miles apart. Greenmount East and Sandtown, Winchester, on the other hand, very similar community conditions. So to give you a little idea about Greenmount East and Roland Park and why we created the program that we did, you can see that Greenmount East skews younger than Roland Park. We only have about 13% of the population is 65 and over. 20% of Roland Park is 65 and older. We can talk about some of the reasons that that might be, and I'll give you some of the stats that play into that in a little bit. It actually is a problem for us at East Baltimore Medical Center. We started our Med-Peds clinic there from scratch, and so had to be able to recruit a patient population across the age range for our residents to be able to care for. And it has been harder for us to make sure that we have a robust geriatric population, with our geriatric population being as small as it is in Greenmount East. You can see that Greenmount East is 97% basically African-American. Now, these numbers are getting a little old, but I would say that probably still is true. We do have a growing Latinx population in Baltimore City. The population in our Latino community is probably up to 8% of Baltimore City. Our African-American populations in the 60-something% or so. And then the rest pretty much is a white population, a very small Asian population overall in Baltimore City. So you can see that the Greenmount East is almost entirely African-American, while Roland Park is very much a supermajority of whites. And the household incomes could not be more different. Where in Greenmount East, the average median household income is less than $25,000 a year. I ask our residents to think about that on a regular basis. Our residents, many of whom are making high $50,000, low $60,000 in terms of salary. It's still probably about 2 to 3 times higher than the household incomes of the patients that they are taking care of. And many of our residents, they are just supporting themselves, not a whole family, on that salary. Roland Park, obviously, much higher salary. And you can see that it's 50% of our patients in Greenmount East, or households in Greenmount East, making less than $25,000 a year. And obviously, the implications on that in terms of education opportunity, in terms of being able to pay a mortgage, the insecurities that result around utilities and food from making less than $25,000 a year cannot be overstated. Certainly our residents worry about how to pay for everything when they are making $50,000, $60,000 a year. And I think probably many of us worry about how we pay for things making much more than that. And the unemployment rate, and again, the data is getting a little old, but was 25% in Greenmount East as of this 2011 to 2015 5-year estimate. I am sure that the unemployment rate went up even more during the pandemic in Greenmount East, where many of the folks work in jobs that were severely affected by the pandemic. Roland Park, the percentage of unemployed is 2.3%. And you can see the poverty rate of about 40% in Greenmount East. And here are the regions with highest poverty index in St. Louis. And I think probably none of these maps surprise anybody who is looking at them today. But again, it's this East St. Louis area. It is North St. Louis. And then if you go out into St. Louis County, the poverty index is quite low. And school readiness is a real issue in Baltimore City. 80%, only 80% of kindergartners are fully ready to learn. And when you get up to 8th graders, now it's down to 50% in Greenmount East. And that compares to 95% of the students who are in Roland Park, right? And all of these things matter in terms of future success, health, wealth, all of those issues. And school absenteeism, where this number just is so striking to me. Almost 50% of the students in Greenmount East miss more than 20 days of school a year. 50% missing more than 20 days of school year. You can think back to your own times in middle school, high school. If I missed a day of school, I was freaked out when I was in middle school or high school. So to miss 20 days or more, which is essentially a month of school, of 20 business days, that's just unbelievable and not hard to imagine how that is going to affect whether you are able to pass or what you're learning in school. And that does have verifiable effects on educational achievement, where you look at the percentage of residents who are 25 years and older in Greenmount East who have at best a high school degree, and that's 2/3 of the residents in Greenmount East. On the other hand, in Roland Park, that's only 7%. So much more, almost everyone you meet in Roland Park has a higher than high school degree. And if you look at the percentages here at the bottom, the 25-year-olds with a bachelor's degree or more, it's the very small minority in Greenmount East who have a bachelor's degree or more. It's 80% of Roland Park. And here's data about the schools that have the highest and lowest proficiency ratings in St. Louis. Again, these track right along with poverty ratings. And you can see East St. Louis, North St. Louis with the lowest proficiencies and really highest proficiencies out in St. Louis County and just a little bit to the west of St. Louis with the best schools. Right, all of this stuff tracks together. And then the homicide rate. This is 10.5 per 10,000. That would be 100 per 100,000 in Greenmount East, right? Those are staggering numbers. I know the homicide rate is a particular issue for both of our cities, where this is one of the rates where St. Louis, I think, is above Baltimore City. Just to put in perspective and remember, the total population in Baltimore City is a little bit less than 600,000. It sounds like in St. Louis, you guys are now down to a little bit less than 300,000. So we're about twice the size of St. Louis. We have around 325 murders per year in Baltimore City, which gives us a rate of about 50 something, 55, 56 per 100,000. I know you guys were actually into the 80s per 100,000 in the last couple of years, right? This is an issue in Greenmount East, but it's not an issue in Roland Park, where no one dies from homicide in Roland Park. Again, only 7 miles away from each other. And the worry that you have every day on the streets in Greenmount East about dying and the trauma that it creates, the PTSD that it creates, the issues around adverse childhood experiences it creates, all of those things, just something that folks in Greenmount East have to worry about and folks in Roland Park never do. And then our built environment preys on Greenmount East, where the number of liquor stores per 10,000 residents is 7.3. That's twice what it is in Roland Park, the rate. And the number of tobacco stores is 5 times the rate in Greenmount East as it is in Roland Park. We have a vacant lot issue in Baltimore City. It sounds like you guys have one too in St. Louis. Again, we were a city that was over 1 million people in the 1950s and 60s, and now down to less than 600,000. So we've lost, somewhere between 400, 500,000 people from the city, which has created a huge vacant lot issue. And it is particularly dense in a place like Greenmount East, where you have blocks that look like this and continue to look like this and are just sitting there. Oftentimes, there may be one house on a street that has inhabitants that are paying to live there, that own the place, and then You will have folks who squat in some of these other places that are quite dangerous to live and are really troublesome for the neighbors. And this is obviously not an issue in Roland Park. And you can see the vacant lot density mirrors, again, this black butterfly that we talked about before and the white L. Here's issues with highest and lowest concentrations of income, low-income housing in the St. Louis region. And again, I don't think any of these numbers would surprise all of you guys living in St. Louis. And the highest concentration of low-income housing centered right around East St. Louis and Barnes Jewish. They did a study with the Baltimore City Health Department in 2014, where they called about 1,000 residents, 60% of whom are African-American, about 35% who were white. That goes along with the demographics of the city, and asked them a number of different questions, including, is it safe to exercise in my neighborhood? And 10% or 2% or 10% said that they strongly agree that it is unsafe to exercise. 2% said they didn't know. Another 20% said they agree that it is unsafe to exercise. So 30% are either agree or strongly agree that it's unsafe to exercise outdoors in my neighborhood. So the things that we ask our patients to do: exercise more, eat better, to be able to lose weight, to be able to care for your diabetes, your hypertension. A third of our patients will tell you, and it's more than a third of our patients, it's most of our patients will tell you that it is unsafe to exercise in the neighborhood. And then comes the food desert. A food desert defined here is that the distance to the supermarket is more than a quarter mile, that the median household income is at or below the federal poverty rate, 185% of the federal poverty level, that over 30% of households do not have a vehicle available, and that the average healthy food availability index score for all food stores is low. So this is, again, from 2015. Now, in Greenmount East, the food desert was 44% in Greenmount East. Since then, the main supermarket in Greenmount East is closed. So my guess is that the food desert now in Greenmount East is 75%. You look at this map of food deserts in Baltimore City. Again, it mirrors the black butterfly and the white L. So when we're telling our patients to eat better, they can't even get to places that will allow them to eat better. And imagine trying to do your grocery shopping where then you would take the groceries home on the bus. That's not easy to do, and especially to do by yourself. These are data for St. Louis, where do residents have the best and worst access to food? So orange is poor access to food. Again, that's East St. Louis, that's North St. Louis, and then some of the places out here in St. Louis County. But okay, so not a lot of access to food in St. Louis, West St. Louis County, but you do have lots of access to personal vehicles in West St. Louis County, where they can get to places where they can buy the food. Here in East St. Louis, it is hard to get food. There isn't food nearby, and people don't have personal vehicles, which allow them to be able to get to a supermarket nearby. And then this is just a map of where the best and worst proximities to jobs are in St. Louis. And then here in North St. Louis, you can see that it has the worst proximity to jobs, also in West St. Louis County. But again, you then put on the map of who can travel, who has a personal vehicle, and it's the people in West St. Louis County who have vehicles, personal vehicles, to be able to get to jobs. You look at the map here, and folks aren't living near jobs and also don't have personal vehicles to be able to get to jobs. In that survey, when they were asking the Baltimore City residents about their lives, they did ask about whether you've had enough food in the last 30 days. And if you lived below the federal poverty level, about 30% of people said they did not have enough food in the last 30 days. Think about whether you ever had to worry about that in your entire life, let alone the last 30 days. And are you unable to pay your full rent or mortgage at some point in the last 12 months? And that again was over 30% of the folks who are below the federal poverty level. And if you have not read the book about eviction called Evicted by Matthew Desmond, which really chronicles issues with eviction in Milwaukee, you're missing out. It is an amazing book, and I think opens one's eyes to all of the implications of being evicted and what it does to people in terms of everything that it upends in their lives, including their health issues. And so finally, this comes up to a comprehensive opportunity index for Baltimore City. And again, you can see here for Baltimore City that this area that has the lowest opportunity follows that black butterfly and white L with the highest opportunity. And if you just compare the two zip codes that I think are of significant interest in St. Louis City, you will see that there are vast differences between these two zip codes, again, that I think none of you are surprised about. The 63105 is a mostly white area, while the 63106 is an African-American area. Unemployment rate of 4% versus 24%. Poverty line, percent below the poverty line of 7% versus 54%. And the median household incomes of $90,000 versus $15,000. Stark differences for areas that obviously are very close to one another. And then all of this has gotten worse in Baltimore City with the opiate crisis. Again, we have about double the number of people in our city that you do, and I think we have about double the number of deaths from opiates and alcohol. It's almost all opiates, and it's almost all fentanyl that's causing all of the issues in Baltimore City. Heroin is disappearing, and fentanyl is killing all of our folks. We have a cocaine problem, but only a cocaine problem when it's in combination with opioids. We have a benzo problem, but only when it's in combination with opioids. Opioids are the root of most of our problems here in Baltimore City. We do not have very much methamphetamine at all. And when it's a problem, it is a problem in combination, a problem in terms of death. It's a problem because of its combination with opioids. And this is to just show us that Baltimore City has a problem with intoxication deaths, but so does the rest of Maryland. And that the folks who are dying from opioid overdose are white, black, and Hispanic, and male and female in Maryland. And it's older folks who die from overdose. It's these 55-year-olds and up, and the 45 to 54-year-olds, and it is not the less than 25-year-olds who are dying from opioids. And this is to just show us that this is just looking at January through June, because these are the latest data that our opioid problem continues in Baltimore City. And here are your numbers. The latest numbers I could find for St. Louis was 2018, where you had about 1,100 people, again, just about half of what we have with about half of the population. So I think the rates are very similar between the two cities. And again, the same problem for you guys. It's the synthetic, and this was 2018. My guess is this number is much higher now. And it's the heroin is going down, and then these are prescription opioids, but it's the synthetic stuff, the fentanyl, that is the worst. And all of that then plays into what the life expectancy is, which in Baltimore City and Greenmount East, it's about 68 years. In Roland Park, it's 84 years. It's a 16-year difference between areas that are just 7 miles apart. And deaths in Greenmount East include the usual things like heart disease and cancer, but obviously also things like homicide, HIV, AIDS, drug and alcohol-induced deaths. And then this is the, I think, culminating slide for you guys, where the life expectancy in 05 is 85 and the life expectancy in 06 is 67, which is, I think by my math, an 18-year difference between those two areas. Just unbelievable with areas that are so close to one another. So our communities have a low literacy rate, low socioeconomic status, and the social determinants of health play a large role in the health outcomes in St. Louis and Baltimore. And that is why we started a urban health program here at Johns Hopkins. Our chair of medicine in 2010 said we were creating leaders in all sorts of subspecialties here at Johns Hopkins, but we were not creating leaders in urban health primary care, and we needed to do something about that if we were going to be the kind of department of medicine that we wanted to be. He brought on board pediatrics, which allowed us to create a med-peds program and in 2010, and then a year later, with funding help from Hersa, we started our internal medicine primary care track. So each of those has 4 residents per year. So med-peds has 16 total. Our internal medicine primary care track has 12 total. And then 3 years ago, pediatrics started a health equity track that has 2 per year, so they have 6 total. So we use urban health as an umbrella term with the 3 programs underneath: med-peds, internal medicine primary care track, and the peds health equity track. And all of these programs do a lot of things together, particularly the internal medicine and med-peds, since I run both of those, but the peds health equity track does a lot of work with us as well. And this is our mission. It is nice to have a primary care track and med-peds program that has a mission. The ACGME makes us tell them what our mission is every year, and it is very easy for us to write a mission statement for our programs. Our urban health programs, the mission is to produce physician leaders who provide exceptional primary care in urban under-resourced communities and who reduce social inequities in our healthcare system through health promotion, advocacy, and/or research. So the goals of our program are to create leaders who are the best doctors they can be, of course, and particularly great doctors who can care for those who are in underserved domestic urban areas. We are not a global health program. We are very much domestically oriented. Our residents need to be comfortable assessing and mitigating the structural and social determinants of health. We've created curriculum all around that. Our residents will become leaders, we hope, in urban primary care, affect change on whatever level they care about the most, promote primary care, feel connected and invested in the community, and hopefully enough so that they want to stay, feel integrated into our departments and our specialists in our specialty of urban health primary care. And this is our curriculum. And what I will say about our curriculum is that these rotations, what you see here, is part of our core curriculum. So this is as core to us as our ICU rotations, MICU and CCU, as core to us as rotations on our general wards. These are rotations that you cannot be on jeopardy in the middle of. You go to these rotations because this is our core curriculum. And we have built this over the last 10 years. We continue to get feedback from our residents about these, and our curriculum continues to mature based on their feedback. It includes things like 2 weeks in our Baltimore City Detention Center, seeing how healthcare is practiced or not practiced in the detention center. It also includes spending time in a van that sits outside of the Baltimore City Detention Center that provides Suboxones to folks who are re-entering after being incarcerated. And we know that that is a really high-risk time for overdose. So they are there to provide Suboxone to folks who have had opiate use disorder so that they do not have problems with overdose as they leave the detention center. It includes 2 weeks of a psychiatry rotation. Clearly, so much of primary care is psychiatry. So we want to give a robust experience in improving the experience and knowledge and attitudes and behaviors when it comes to psychiatry. It's a month-long addiction rotation. All of our residents do the 8-hour X-waiver training. All of our residents see what practicing addiction medicine is like in a clinic, as well as in many of the local nonprofits that are involved in caring for folks with addiction. This is one of the favorite rotations of our residents, and probably no surprise that many of our residents have gone on to do addiction medicine fellowships. They do 2 weeks of homeless medicine at Healthcare for the Homeless, which is just an amazing clinic here in Baltimore. They do 2 weeks at adolescent health for our internal medicine primary care clinic, for our internal medicine primary care track, and at Planned Parenthood of Medicine in our med ped. So at Planned Parenthood, they put in Nexplanon, they can put in IUDs, they can see abortions. And I think we are probably the only internal medicine primary care track in the country that has its residents all do an adolescent health rotation, focusing on STIs, contraception, motivational interviewing, really important things no matter what the age is. They do a rotation with the Baltimore County Health Department, a potpourri rotation to see what services a well-run health department can provide. They do a 4-week outpatient HIV hepatitis C rotation that includes time at a federally qualified health center that traditionally cared for our LGBTQ plus community in Baltimore City, and at our Bartlett Clinic here at Johns Hopkins, which is our HIV clinic at Hopkins. And then many of our residents have such a significant interest in HIV that we make it possible for them to do the practicing HIV specialist certification, which requires them to have a second longitudinal clinic during their last year of residency at either the Bartlett Clinic or at the FQHC, which is called Chase Brexton, providing HIV care. Immigrant health happens both in our clinic and also at Chris Prater's All Clinic at Highlandtown, which is a refugee clinic that it sits next to the IRC and cares for a large Nepalese, Bhutanese, and now Afghani population coming up there. And we do an urban community medicine rotation, which is a 2-week rotation that has our residents meet many of the nonprofits that provide services in the area for our patients, so that our residents know of the services and actually can help with some of the warm handoffs for particular patients who need that. And then we have lots of electives as well. These are not part of the core rotations, but include things like chronic pain and obesity and high utilizer clinics that have all been created in the past, often by our residents, but then so many of our residents are interested in these electives, it allows them to live on and on. And then we have lots of policy rotations because many of our residents are interested in policy, whether it's on the national level with HHS or the Centers for Medicaid and Medicare, which are actually on the Baltimore Beltway, not Washington Beltway, or our residents can go down to DC to HHS. They can work with elected officials or nonprofits like Public Citizen in Washington, DC. It is nice to be so close for us to Washington, DC. So in the end, what are we hoping that our leaders in urban health primary care do? And really it comes down to hopefully whatever it is that they want to do, whatever they think is going to allow them to become leaders in urban health primary care. What we had thought about when we created the program were things like primary care researchers, clinician educators, CMOs of federally qualified health centers, office medical directors, folks who are involved with non-governmental advocacy organizations, and policymakers, folks who are working in health departments, those type of things. So what are our grads actually doing? Well, we have graduated now 8 classes from each of our programs from Med Peds and our urban health internal medicine primary care track. I think in the end, the test for whether we have been successful is what are our graduates doing now? And 28 out of 30 of our graduates for Med Peds are doing primary care, urban health, many in the community, many in sort of academic community partnerships. 6 in academic. We have a number of folks who are in the National Clinician Scholars Program currently. We've had a lot of folks who have done addiction medicine fellowships, or GIM, or Gen Peds and adolescent medicine fellowships. We've had 2 people who've completed adolescents, and we have 12 people who are already in leadership roles, only 8 years out of having our first graduates from the program. Leaders in things like primary care and med ed, incarceral medicine. One of our residents is the chief medical officer for all of the jails in Rhode Island. We have folks who are leaders in street medicine and addiction, DEI, and high utilizer clinics, folks who are running high utilizer clinics already. We couldn't be more proud of what our graduates are doing. And here's for our urban health internal medicine primary care track. Again, 8 graduate cohorts so far there. Not as good percentage who've gone into urban health primary care. It's been 64% there versus 36% doing something else. Most of which, when they do something else, is hospital medicine or ID fellowship. But still, I think much better than in general. If you look at primary care tracks across the country, at best 40% on average are going into primary care. We're at 64. We want to be at 100. That is what the goal is for our program. And again, leaders in many of the same things that our med peds graduates are leaders in. So that's what we have done over the last 10 years here. And so our hope is that our experience here helps people to be aware of the social and structural determinants of health at play in our community here and in St. Louis, and that our experience shows that this can be done, that this can be done well, and that in the end, graduates go into the things that we are hoping that they do, that we are effective in what we're doing, and that we will have more programs across the country created that are urban health residencies. There is a new one in New York City. Mount Sinai has created a new basically urban health med peds program at Mount Sinai. There are a number of new internal medicine primary care tracks that are very similar that have popped up across the country. And I think that this is an important part for every institution to think about what they are doing for their community, how they are best serving their community, and are they producing physicians who are going to impact their community. We have felt like we have started to do that here at Hopkins, and we hope that we will be able to continue that on into the future. So thank you for having me, and I am happy to answer questions over the next few minutes.
Dr. Feldman, thank you so much. What a fantastic talk and such important work. We're really glad you joined us here today. We've got a number of questions coming in. I think as I kind of throw up our QR code for folks watching at home, how do we get started? You know, this is amazing. We love to do this, but there's certainly a lot of barriers and a lot of work on the ground. Where do you begin?
So I think there's a couple things. One is there has to be the will. The leadership has to decide that this is an important area that needs resources devoted to it. That needs the leadership in terms of residency program leadership that are devoted to it, and then the time and energy to be able to create the curriculum. We've been able to do a lot of this curriculum, and I did not show some of the credits. Obviously, I've had a lot of help in all the work that I've done, and particularly from the federal government. We've had now 3 grants from the federal government from Hersa for primary care enhancement. And this latest one is $1.8 million. So we've been able to finance a lot of this on the back, thankfully, of the federal government. And Hopkins, fortunately for Hopkins, has had to pay very little. Yes, they paid for our residents, but our residents have certainly given back in terms of service. So it's a will, it's finding the money, which is out there, and it's making this a priority.
Thank you for that. You talk about obviously having some grant support. What other partnerships are critical in developing this track? Do you have a role with the VA in this process? And how much of these rotations are kind of observational of how these things work versus an active,
Yeah.
care role?
Great questions. So Maryland, University of Maryland, is really connected with the VA. They actually, the hospital is physically connected to the VA hospital here in Baltimore. So they have had more access to the VA than we do. I have contacts with the VA, but we have not done as much with the VA as I would hope. Mostly our community partners are the FQHCs in Baltimore, and we have a lot of FQHCs in Baltimore, including the one that Chris used to work at. Chris was a great preceptor for us when he worked at Highlandtown and worked with our residents who were doing—
Not a surprise. Not a surprise.
Yes, doing refugee medicine. We were very sad when Chris left for St. Louis. And so a lot of it has been building these partnerships with the FQHCs, Healthcare for the Homeless, Chase Brexton, with Baltimore Medical Systems. And I would say almost all of our rotations in the community, our residents are practicing medicine in the community. They're practicing medicine and healthcare for the homeless. They are practicing medicine in the Baltimore City Detention Center. They are practicing medicine at Chase Brexton, providing HIV care. They are practicing medicine, providing refugee care at Baltimore Medical Systems. There are a couple rotations that are meant to be more observational, like our Baltimore County Health Department rotation, where the idea is to see the services that are provided, or with our urban community medicine rotation, where the idea is to meet the nonprofits in the area that are doing great work. And one of the things that our residents do when they meet the nonprofits often is to engage in teaching them, teaching the folks who are patients or clients in the nonprofit about medical issues. So we do a lot of education through these as well.
Thank you for that. Looking back earlier at the talk, you're talking about the health literacy issue. A couple questions about that. One, do you know of any interventions that have consistently shown to improve that health literacy and therefore outcomes? And are you looking in your own program for any, metrics of success in that regard for how your training is improving that in that community?
Yeah, probably not as systematically as I would like to, is the answer to the second part. I do a orientation talk that is similar to this for our residents that focuses on the health literacy issues and talks about some of the ways to mitigate those issues with health literacy. I think the biggest one and probably the most evidence-based, although I don't know the evidence really well, is Teach Back. And so we try to instill making sure that our residents are doing Teach Back with their patients, whether that's in the hospital or in clinic. But I think it would be very helpful, useful, important for us to study more whether our residents are really communicating the way that we would hope they do with the health literacy, the issues with the way they are.
One of our residents asks, they say they're very happy to see the psych rotation in your IM primary care track. Can you talk about how that psych care is incorporated? Is it embedded or integrated to behavioral health system, or is it more a referral system?
So the psych rotation is a 2-week rotation where you are actually working. It's almost in some ways sort of like medical school. You're back on the psychiatry rotation. Part of the idea is to be able to tell sick from not sick, the same way that you need to do that with patients of that you see in the ED or on the floors or in the ICU. Are they sick or not sick? Do they need to be where they are? Is this patient sick or not sick from a mental health standpoint? Where do they need to be treated? Do I need to send them to the ED? Do I need to have them inpatient? They do a significant amount of work in the ED, working with our psychiatrists as patients come into the ED, and they do a significant amount of work on the consult service with psychiatry. And all of that, all of these rotations, the idea is they've spent enough time in clinic, in our clinic at East Baltimore Medical Center and on the wards, that they are beginning to know what they don't know. And so they do these core rotations in urban health primary care, and they get out of it what they need in order to be able to take care of their patients back in clinic and in the hospital. If you are not practicing psychiatry in clinic as a primary care physician, then you're probably not doing the full role of a primary care physician, right? There's so much mental health that is centered in the primary care clinic And so our hope is that our residents feel even more secure in their knowledge to be able to practice psychiatry, mental health care in the clinic.
Wonderful. And probably the last question, if you've got time, someone asked, how do we engage local NGOs, food pantries, and other charity organizations to help with improving the quality of life for these families and their kids? They say we have many organizations helping with food, clothing, but we need more help with sustainability with ongoing educational resources.
Yeah. So one of my associate program directors, that's her job. We also have an organization called Medicine for the Greater Good that started at our Bayview campus. That's job is to connect with the nonprofits in the area, right? It needs to be someone's job to do this, or it doesn't get done. And so we prioritize this as an important role. And so advocacy, community involvement is a job, is one of the roles of our associate program directors.
Perfect. Well, again, Dr. Feldman, thank you so much for your time this morning. Thank you for sharing your work. It's very applicable to our situation here, and I hope we can follow suit. Dr. Prater, any last comments before we go?
Since we're over time, I will defer, but I will echo what you said. And thank you, Dr. Feldman, for bringing some comparisons among the cities. I've lived in both cities. I've worked in both cities. And for someone such as yourself, who has not lived in St. Louis, we appreciate bringing those comparisons to light. And I'll echo what Dr. Hickman said, you know, call to action is certainly an important title for your talk.
And if there's any way I can be helpful in that in the future, please let me know.
I think we'll probably take you up on that. Thank you again, Dr. Feldman. Have a great one. And thank you everyone for coming today.
Happy holidays, everybody.
You too.
I'm not sure if our recording has ended, but Lenny, thank you so much. It was really wonderful.